Welcome to this session entitled Ovarian Cancer, Better Data, Better Outcomes. I'm Frances Reid and I'm Programme Director for the World Ovarian Cancer Coalition. This session focuses on improving data, and I'm delighted to introduce Andy Nordin. He's a gynecological oncologist from England. He is past president of the British Gynecological Cancer Society and is a clinical advisor for the National Cancer Registration Service in England. And he's here today to tell us about the Ovarian Cancer Audit Feasibility Pilot, which, as you might guess, is to do with ovarian cancer data. Welcome, Andy, and thank you very much for joining us. And I'm going to ask, first of all, if you can fill in some background on what sort of data is routinely collected on women who have ovarian cancer in England.
Hi, Francis. Well, thank you so much for inviting me along to this fantastic forum. Towards the end of the 1990s, the government in the United Kingdom realised that our survival for most of our cancer tumour sites in the UK were below the survival rates for comparable countries in Europe and the rest of the world. And we focused on a big program of improving cancer treatment and configuration of cancer care. The National Cancer Plan was published in 2000. And as a result of that, gynecological cancer services were coordinated and centralized into a series of cancer centers and then cancer units that diagnosed patients and referred them into centers. We set up something like 40 cancer centers in England. Part of that process was a realization that without high quality data, we really aren't able to improve services. And so the National Cancer Intelligence Network was set up in 2007. And the main benchmark of that was a process of collecting cancer data routinely through routine clinical processes. So we now have in the United Kingdom what's called the COSD data set, which includes every patient who is suspected of having cancer, referred in with a suspected diagnosis, every cancer diagnosis, the tumor type, the tumor stage, the performance status of those patients should all be documented by the multidisciplinary teams that are managing those cases. All of the pathology data is automatically uploaded to the Cancer Registration Service, so we have high quality pathology data, and they have access to imaging as well. And then there are separate data sets for what's called the SACT chemotherapy data set. So every cycle of chemotherapy that's given in England is automatically captured directly onto a database. And we have access to radiotherapy as well for other tumor sites, the radiotherapy data set. And then every operation that's done within the NHS, because it's a unified health service, we have hospital episode statistics data that is also routinely captured for everything that is done. So our ambition with this audit, we've been very keen to set up a national audit that would help us identify areas where we could improve our services and improve the treatment for women. Our ambition was to see how much quality data we could extract from these existing data sources without putting any additional burden of data capture. On the underlying principle that the most important factor in any sort of cancer audit is that you capture every patient who's diagnosed, rather than an opt-in audit where cancer centers might want to upload data on their surgery or their own diagnoses or whatever. There's obviously a massive risk of selection bias. Whereas in this sort of national registration-based audit, we are capturing all of the data on all of the patients. Warts and all, if you like, including the cases that may not get access to treatment or may not do well.
I gather there are other audits for other cancer sites in England as well, but this is different because it just focuses on data that already exists.
Yeah, that's correct. There's already, there have been audits for some years on bowel cancer, lung cancer, prostate cancer, upper GI cancers, for example. We were very much hoping that ovarian cancer would become one of those audits, but those audits are actually extremely expensive to run because they require teams to collect data separately and upload those data items to a central audit registry. And then there's a lot of administrative costs for the the managers of the audits to go back to teams and chase data that's missing and chase cases that are missing. And there is still that risk of case selection, whereas this is a different approach, which we're hoping, if we can, the reason why we've called it a feasibility pilot is to see how effective it can be. But if we can demonstrate, and we believe we have demonstrated that it's effective, then it's something that hopefully we can roll out for other cancers, uterine cancer, cervix cancer, vulval cancer, and every other type of cancer, because the data is there. The NHS spends a lot of money now collecting this data as it goes about coordinating its care. And what we're really wanting to do now is extract the data in a meaningful way that's meaningful to the clinical teams that are looking after the patients, also that's meaningful to patients and to patient representatives and to the charities. So this project is actually a collaboration between 3 charities, the 2 ovarian cancer charities in the United Kingdom, Ovarian Cancer Action and Target Ovarian Cancer, and also the British Gynae Cancer Society, which is our professional society. So if you like, it's actually the clinicians are funding this themselves, because we contribute to the running of the BGCS, and British Gynae Cancer Society is one of the 3 partners that are helping fund this audit. And it's done in collaboration with the National Cancer Registration Analysis Service, which holds all of this data in these massive data sets, and have very experienced analysts who are experienced at extracting the data and linking the data sets together.
So the involvement of the charity partners, BGCS, Ovarian Cancer Action and Target Ovarian Cancer, has been fundamental to getting this project off the ground.
It was crucial. It was absolutely crucial. So when I was the president of the BGCS, I was desperate to try and get a project up and running, and campaigned far and wide. And I was delighted that those 2 ovarian cancer charities were prepared to come and join us in that collaboration. And it's been a really effective partnership over the last 2 years. It's a defined 2-year project. We're coming towards the end of it now, but we very much hope that the outcomes that we've produced, the potential for improving care from utilization of this data, will encourage the politicians to recognise this as an important audit, and will fund it as an ongoing concern.
Okay, so the partners have been involved in helping with the development of the pilot study.
Yes, we've got a steering group and a management group, and that is representatives of the 3 funding partnership charities, and also NCRAS, the analysts. And I have a role with the charity, but also with BGCS, so I'm sort of coordinating and chairing that group.
You mentioned that you hoped it would help improve outcomes for women with ovarian cancer. I was going to ask you next about, what is it that you were hoping to achieve with this? So obviously improved patient outcomes in the future, hopefully, but what were you looking for in particular?
So we've known for some time that our outcomes were falling behind those other countries, particularly the ones that we've been able to benchmark against in the International Cancer Benchmarking Partnership, which is Scandinavia, Canada, and Australia. And we really needed to try and understand why that was. And with the early days of the NCI, and we did some exploratory work looking at ovarian cancer treatment and management, and we were really stunned when we realised that some 15% of our ovarian cancer, and we talk ovarian cancer, we're also including tubal cancer and peritoneal cancer. So that 15% of our ovarian cancer patients were dying within 2 months of diagnosis. We almost fell off our chairs. 31% were dying within 12 months of diagnosis. And when we looked at how those patients were diagnosed, this was particularly affecting elderly women. It was particularly affecting patients who were diagnosed through an emergency presentation. So they weren't referred by their primary care clinician, by the GP, as a suspected cancer. They became very unwell, and they were admitted as emergencies to hospital, and they were then diagnosed subsequently as having cancer. And we realized that group of women were doing very badly. We didn't really understand why they were being diagnosed so late, and why they weren't getting treatment. And so we wanted to delve into that. And one of those issues was to try and understand whether there were variations around the country, whether there were some areas in the country that were perhaps getting a higher proportion of patients into treatment, whether there were some areas, some regions, some teams, some hospitals that were better at getting patients into surgery, for example, and whether that may be one of the major reasons why there was the difference in outcomes. So the first main project we embarked on was a profile report, trying to get an idea of what was actually happening as a sort of a baseline in the UK. So we looked at survival since the turn of the century. And I guess that's a good news story, because we can see that ovarian cancer survival has improved, but 1 year and 5 years survival has improved by about 10% over the course of that time. So all of the investment in resource and the reconfiguration of services and the training lots of surgical gynae-oncologists and the improvements in chemotherapy and all of those, the establishment of multidisciplinary teams, all of those things are actually making a difference. So that was encouraging, and it was one of the first parts of that presentation. The second part of that report, which was really interesting, was looking at regional variation, and we were really quite surprised at seeing how much variation there was in 1 and 5 year survivals across the country. This is just in England. Unfortunately, we couldn't include the other countries because of the data sources. But there was a 1 year net survival variation between 63% and 75% across the different 19 cancer alliances, which are the regions. And the 5 year survival rates vary between 28% and almost 50%. So really quite substantial variations across the country. It's also quite substantial variations even in incidence. And of course, when you have differences in incidence and you have differences in survival, you also have differences in mortality, which are the deaths from ovarian cancer. So when we look at these on funnel plots, which show distribution across the country, we can see really quite extensive variation. So the next part of the report was, the next part of the project was a treatment report. And I guess this has been the main body of work that we've been focusing on for the last 12, 18 months. That report has just been published, came out on the 11th of November. And in the treatment report, we look at, we take all of the patients diagnosed over a 3 year period, which is a total of 17,155 patients. So it's a very large cohort. This is every woman in England who's been diagnosed with ovarian cancer or tubal or peritoneal cancer. We break them down into groups of those who had no surgery or chemotherapy. So this is essentially no anti-cancer treatment at all, didn't get access to treatment. They hopefully will have had some palliative care appropriately. They may have had some hormone treatment, but they certainly didn't have any actual anti-cancer chemotherapy or any operations to debulk the disease. And that was just over a fifth, 21.9% of patients didn't get access to treatment.
That is shocking, isn't it?
It's shocking, and it's real world data. This is actually really what happens. This is not, this is not the randomized controlled trials where patients are selected for trials. This is actually real warts and all what happens to patients in the UK, in England, diagnosed with ovarian cancer. And in addition to that, there was another 18.7%, almost another fifth of patients who got some palliative chemotherapy but didn't actually get an operation. And I guess that sort of explains why we were seeing previously with our original mortality report, 31% of patients dying within a year, because these patients presumably just weren't well enough when they were diagnosed, when they were actually accessed by the teams to go on and have the proper course of treatment, have the chemotherapy or have the surgery, or hopefully the combination of the two. Whether that's, and then when we looked at regional variation in those groups, we see that there is really quite a large variation. We've demonstrated these on funnel plots, and for those people who aren't familiar with funnel plot, the line that runs across the middle of the funnel plot is the national average. And then we've got what is effectively 2 standard deviations and 3 standard deviations from the norm. So those within the 2 standard deviations, either side of the mean, they are sort of within the normal range, if you like, and those that are sitting outside of those dotted lines are those cancer alliances, those regions that are outliers, either with more patients being treated or less patients being treated. And there is
the larger the size of the dot is, the larger the number of patients within a cancer alliance.
Correct. And as you move down to the right-hand side of the funnel plot, you can see that the confidence intervals get tighter because the numbers are larger. So the statistical variation is less. The smaller cancer alliances are back on the left-hand side where the numbers are smaller. But the statistical principles are still the same. If you sit outside of those lines, that suggests that that your an outlier nationally compared to the national average. So we've looked at that for each of the different five tumor models, if you like. That is no surgery or chemotherapy, chemotherapy but no surgery, and then we can look at the patients who have surgery and whether they had upfront debulking surgery or neoadjuvant chemotherapy and interval debulking surgery. All of those sorts of analyses can be done on the population level. So we did the analyses just initially on the raw data. It is exactly what happens when the patients are referred into our cancer centres. But because there could well be, there is variation around the country. For example, retirement areas will have a high proportion of patients who are elderly and may have extra comorbidities. We also did some adjustments. We've actually looked at treatment by age group, and it's really quite interesting to see that particularly women over the age of 80, but even women over the age of 70 have a much higher chance of not getting any surgery or chemotherapy. And there is variation in the use of neoadjuvant chemotherapy as we get into women in their 60s and 70s, and an increase in proportion of women who get chemotherapy only as the age groups go up, so effectively just sort of palliative treatments. So we know that age is a really important factor here. We've sort of known that from the early days of the NCIN work. So when we're looking at regional variation, after doing the raw unadjusted analyses, we've also then done two models of adjustment. The first model of adjustment adjusted for patient's age, for tumor stage in case there were variations in tumor stage, and for tumor type, because certain tumor types like serous carcinomas have got very different patterns of treatment to some of the others. And then we did a full adjustment where we included a factor for deprivation index, which in the UK we're able to do by postcode, and that's a fairly valid, reliable way of assessing an individual's socioeconomic status on their postcode, and also for a Charlson comorbidity score. We know that someone's performance status is probably the most important factor when they're diagnosed, is our ability to be able to give them chemotherapy and surgery. Performance status is one of the data fields that we routinely collect, but unfortunately has been a data field where the teams have not been very good at collecting it, and we only had data in the region of 30 to 40% for performance status, so we couldn't use that as a factor for our analyses. But comorbidity can be captured using hospital episode data. If there's been an inpatient episode in the 6 months prior to diagnosis, it correlates very strongly with access to treatment or not treatment as the comorbidity score goes up, but our system is not very sensitive for capturing it. Unfortunately, we only seem to capture comorbidities in about 15% of our patients. So we need to improve the data completeness, and this is the challenge with this type of project, is that you can only analyze the data that's in the system. And we are dependent on the teams as they're working really hard in the clinical context and they're having their busy MDT multidisciplinary meetings, diagnosing and managing patients, to actually capture those important data items as they go on, particularly performance status. And that's a message for us going forward.
Do you believe almost that performance status is more important than stage?
I think performance. I think it's more important than stage. I mean, stage in ovarian cancer, if you think about it, a patient is stage 3 if she's got a single solitary metastasis in a lymph node, and she's also stage 3 if she is admitted as an emergency with an abdomen completely full of tumor, with a very low albumin and a chest infection related to her disease and or subacute bowel obstruction. She's still stage 3. But her performance status could be 0 if she walks into the clinic and is diagnosed in fit and healthy state and is obviously able to cope with any treatment that we can throw at them. Whereas the performance status might be 3 or even 4 if she's brought in as an emergency and is barely able to cope with anything. And so I think performance status is absolutely crucial. And if we're looking at regional variations, it may well be that in parts of the country where there is deprivation and where the patients have poor access to primary care, for example, they may not be getting that diagnosis and referral at an earlier chronology in their disease, and they may be being diagnosed with a much poorer performance status. So it's important as we go forward and we take this project forward in the future that we get better at capturing performance status at the time of diagnosis.
Okay, so the hope is that cancer alliances and even hospitals, individual hospitals, look at the data. Now, there are two sites, aren't there? There's a public-facing site, and then there's access behind the NHS firewall to this data. And you're hoping that they will look and interrogate this data.
Absolutely. So one of our ambitions with this project was to put as much data as we possibly could out into the public domain. So our reports, which include, they name the cancer alliances, so we're not hiding any data. That's all out there in a public website. If anyone wants to look at that, if they just Google NCIN, National Cancer Intelligence Network, Gynae Hub, and that's a public website that we publish all of our outputs. But there are issues about data confidentiality, and it's very, very important when we're putting data out there that patients couldn't be identified individually, and there are very strict rules on confidentiality of data. But we are able to put much more granular data onto a separate website, which is called the CancerStats2 website, and it's behind the National Health Service firewall, so it's only accessible to employees of the NHS who have appropriate reason to go onto that website and can get a password. And we have very granular data there. So we've got all of the data by actual hospital, that whichever hospital, or it's called hospital trust, diagnosed that case, we can then see how many of those patients are being treated, how many of them got no chemotherapy or surgery at all, how many got only chemotherapy, how many got an operation followed by chemotherapy, how many got chemotherapy followed by surgery, how many had surgery alone without any chemotherapy. That's all broken down there, and also by which hospital trust they were managed by. And we can also break that down by the tumour stage, by FIGO stage. Yeah. That's all available to the teams, and we think this is going to be a really powerful tool. I mean, we've already used it ourselves in our own local team to, pardon me, to go in there and try and really understand what's happening to our patients, and to be able to compare what's happening to our patients to what's happening to patients in the neighbouring hospitals and the neighbouring cancer centres and to cancer centres around the country. And if we appear to have an issue, if we appear to be operating on a lower proportion of patients, or we have a lower proportion of patients who are getting chemotherapy, or we have a lower proportion of patients who are getting upfront surgery compared to neoadjuvant chemotherapy, then we can start to question why that is and look at our processes.
And that there may be many reasons. There may be
many reasons. It might be factors that happen long before the patient ever presents to our team. There may be socioeconomic factors. It may be performance status. It may be comorbidities. It might be age. Particularly that stuff behind the CancerStats2 is all unadjusted. It's real life data on what's happening to our team. But it may also be processes within our healthcare institution. It may be that patients are not getting to our team quick enough. They might be being admitted and spending weeks on a care of the elderly ward, or a respiratory ward, or a gastroenterology ward with a bowel obstruction or whatever before they get to us. It might be taking us too long to get the diagnosis made. We might be more reluctant than other teams to give patients total parenteral nutrition and try and get them better, to give them some chemotherapy. We might be more reluctant to get them into surgery. It gives us a chance. It gives us something to work on, to actually look at our processes and to see if we can improve the quality of the care that we're giving.
That's brilliant. You said the project is about a 2-year project and it's coming towards the end. What are you hoping to do before it comes to an end?
Yeah, so we've got 2 smaller projects still to do. The first one is to revisit what we call the short-term mortality analysis, which is what we've done previously with the NCIN, but do that by regional variation as well. So these are looking at in depth at the patients who die within a year of diagnosis, and to try and get a bit more of a granular assessment of these cases. Most of those cases we know are going to be diagnosed as emergencies rather than elective admissions, so that there's patients who are going to come in to accident emergency, to the emergency department, unwell from their diagnosis without them even having had a diagnosis being made at that point in time. But we're going to look at that and see if there's regional variation, and see if there's regional variation actually accessing cancer treatments for those patients, particularly, I guess, initial chemotherapy, but also getting some of those patients into surgery. We've previously looked at that on a national level. We want to be able to look at regional variation in that. And the second remaining project is something which is extremely exciting in the future, and it's really we're going to do an initial analysis, and that's to see how much we can use the data that we've got already to analyze the surgery that we're doing. So this is looking at the cohort of patients who are getting debulking surgery by looking at the hospital episode statistics data, looking at the OPCS4 procedure codes. So we can derive a surgical complexity score. So if a patient may be having just a hysterectomy, tubes and ovaries and omentectomy, or she might be having bowel resection, splenectomy, peritonectomy, all those sorts of things. So we're hoping to be able to derive a surgical complexity score, 1, 2, or 3 for those patients. And we have a data item that's should be being routinely collected called residual disease. It's very simple. It's 0 residual disease less than a centimetre or more than a centimetre. And every patient who has ovarian cancer surgery should be having that field completed by their multidisciplinary team. Data completion, that's a relatively new field, and data completion for that has been poor. But in the future, we very much hope that the teams will grasp that, because most of the data is automatically captured. In the MDT, we just need to make sure that we capture the FIGO stage, the performance status, and the residual disease. And with those 3 simple data items, if they're paramount in people's minds, and that we make sure that every patient has it captured, we can do all of this stuff later on with the data by merging the hospital procedure code data along with the cancer registration data, and we can look at how radical the surgery is being, and whether there are regional variations in radicality of surgery, and whether there are regional variations in residual disease. So that's really the first within the 2-year project. We're just going to be able to do some exploratory work with that. But what we're very much hoping is that this audit will be picked up and supported with public funding from the end of the project onwards as an ongoing audit, and that we can really develop that area of surgical and surgery analysis, again using just the routine data items that are collected in day-to-day management.
And that all of these areas that you've been exploring contribute into the discussions with the NHS, with the government, about what more can be done to improve care.
Absolutely, and the data that comes out of this can then feed into commissioning discussions and standards of care, and discussions about configuration of services and further centralization of care. All of these sorts of things need data. If you can't have sensible discussions, meaningful discussions about any of these things unless you've got quality data. And our argument always with this project has been that we're so much time and effort now is spent in the NHS collecting the data items, and what we're trying to do here is to turn that round and say, well, this is what it shows us. Let's use the data and see how we can use it then to improve care in the future.
You use what is there, basically.
Use what is there. Use what is there.
Yeah. Now, we said right at the beginning that England was probably in a fortunate position in the amount of data it already collects, and because we have a national health service, that sort of facilitates that collection. If you had any sort of advice for clinical groups or advocacy groups in other countries where perhaps even data is very basic or perhaps non-existent, what would your advice be?
Yeah, it's a very good question. We are very fortunate. I think in England, actually, we're very good at perhaps showing, how bad we are. We're very good at collecting data, and because of the centralized coordinated health service, I think that it's given us the opportunity, and we are very, very good at collecting data, and that may be one of the reasons why perhaps our survivals appear to be, perhaps less than some of the other countries in the world, because we are capturing data on absolutely every patient who's diagnosed. In my view, a little bit of data on everyone is so much more valuable than an awful lot of data on selected cases. And so I guess my plea to anyone sort of trying to develop a health service is to do all you can to get some very basic cancer registration data, so you know how many cases you've got, what they are, what type of disease they are, what their stage is, and some very basic stuff about how they're being managed, because that is so much more valuable when you're looking at health inequalities. We're trying to identify groups of the population who may not be getting access to the quality of care that other groups are. You need data on everybody. If you set up elaborate data sets that require lots of information about the specific cases, you will only get data collected from major centres where patients have been referred in, and those patients by definition are going to generally be highly performing and have better outcomes. So it's really, really important. Patient population level registration data really, in my view, is the key to this. And you've got to start at a fairly fundamental basic level, and you can develop the other layers of data as you go on, but you've got to start with basic cancer population level cancer registration data.
Thank you very much, Andy, for your time, and we wish you well for the remainder of the project in its current form, and hope very much that it gets adopted at a larger scale level.
Thanks, Francis. It's been an absolute pleasure. Thank you.
Thank you.